let's take a quick look at this biochemically significant element, iron. Iron is an important trace mineral because it is essential for function of numerous proteins in cells, including proteins involved in oxygen transport and storage, in electron transfer, and also as an important component of cytochromes that are involved in oxidation-reduction reactions and in synbiotic metabolism. Mammalian cells regulate expression of proteins involved in iron uptake and sequestration to ensure that iron supplies are adequate to meet metabolic needs but not sufficient to cause toxic damage. Like other group 8 elements, iron exists in a wide range of oxidation states, from -2 to +6, although +2 or ferrous and +3 or ferric states are the most common and biochemically significant. This most important property of accepting and donating electrons readily, interconverting between ferrous and ferric forms, makes iron a very important element in many biochemical processes. As we have seen and will see in the succeeding lectures, this capability of iron makes it useful as a component of cytochromes in the electron transport chain, in oxygen-binding molecules, and many other enzymes. However, iron can also be a double-edged sword. Iron, especially if present in excess, can also damage tissues by catalyzing the production of reactive oxygen species or ROS. This is exemplified by the conversion of hydrogen peroxide to hydroxyl free radicals that attack cellular membranes, proteins, and DNA. Iron is quantitatively the most important trace element. The human body contains 4 to 5 grams of iron, which is almost exclusively present in protein-bound form. We all know that free or unbound iron is toxic to the cells because of its propensity in facilitating production of the various reactive oxygen species. Approximately 3/4, or around 72% of the total amount, is found in heme proteins, mainly hemoglobin, approximately 2.5 grams, and in far lesser amounts in myoglobin. About 1% of the iron, on the other hand, is bound in iron-sulfur clusters, which function as cofactors in the respiratory chain, in photosynthesis, and in other redox chains. The remainder, or around 26%, consists of iron in transport and storage proteins, specifically transferrin and ferritin, respectively. Iron, which is obtained from the diet, has a recommended dietary allowance of 10 mg for men and postmenopausal women and 15 mg for premenopausal women. The average American diet contains around 10 to 50 mg of iron. However, only a small amount, around 10 to 15%, is normally absorbed, and thus iron deficiencies are fairly common. The iron found in the diet is basically of 2 types: heme iron and non-heme iron. The iron source from animal meat is in the form of heme, which is readily absorbed and is thus the best source of iron in the diet. Heme iron is sourced from meat, fish, and poultry, but not in milk or dairy products. Thus, milk needs to be fortified with iron to be an adequate source for this element. The non-heme iron found in plants is not as readily absorbed. This is in part because plants often contain oxalates, phytates, tannins, and other phenolic compounds that chelate or form insoluble precipitates with iron, preventing its absorption. The iron found in supplements are mostly of this form and is thus poorly absorbed. The absorption of iron predominantly occurs in the duodenum and upper jejunum. Its absorption in the duodenum is tightly regulated as there is no physiologic pathway for its excretion from the body. Thus, the body, under normal circumstances, needs to guard its content of iron zealously. Via obscure mechanisms, the absorption of iron is enhanced in people who are deficient for it and is decreased or dampened for those with iron overload. It is noteworthy to note that a healthy adult male loses only about 1 milligram of iron per day because of such mechanism. Adult females, on the other hand, are more prone to iron deficiency because some may lose excessive blood during menstruation. To continue, the physical state of iron entering the duodenum greatly influences its absorption. At physiologic pH, ferrous iron or iron plus 2 is better absorbed. However, in the gastrointestinal tract, ferrous iron can rapidly oxidize to the insoluble ferric form. When in the ferric or iron plus 3 state, iron forms large complexes with anions, water, and peroxides. These large complexes have poor solubility and upon their aggregation lead to pathological consequences. In addition, iron can bind to and interfere with the structure and function of various macromolecules. However, gastric acid lowers the pH in the proximal duodenum, enhancing the solubility and uptake of iron. When gastric acid production is impaired, for instance by acid pump inhibitors such as the drug Prilosec, iron absorption is reduced substantially. In short, under conditions of neutral or alkaline pH, iron is found in the ferric state, and at acidic pH, the ferrous state is favored. There are various factors affecting the absorption of iron. This table summarizes these factors. As stated previously, the physical state and ionic form of iron profoundly affects its absorption. Heme is the best form of iron for absorption, followed by the ferrous form, and lastly by the ferric form for reasons explained before. Phytates, tannins, and other substances inhibit iron absorption by chelating iron or forming large complexes with it, preventing its absorption. Iron overload inhibits iron absorption for mechanisms unknown, and antacids increase the luminal pH, resulting to the oxidation of ferrous iron to its ferric form. The competitors lead, cobalt, strontium, manganese, and zinc are divalent cations that will compete with iron for a certain non-specific divalent metal ion transporter, which we will see later. And lastly, these factors facilitate iron absorption. Stomach acid, ascorbic acid, and citric acid for decreasing the luminal pH, preventing the oxidation of ferrous iron to its ferric form. Amino acids, in a way, facilitate iron absorption indirectly by increasing the synthesis of globin that will stimulate heme biosynthesis and thereby increasing the demand for iron, and high altitude, exercise, and pregnancy all increase the need for oxygen transport, necessitating the increase in heme and globin synthesis and subsequently iron requirement. Let us now proceed to discuss how iron is absorbed. Enterocytes in the proximal small intestines are responsible for the absorption of iron. This illustration shows the enterocyte with the intestinal lumen on the left and the serosal side on the right. Iron found in heme is absorbed directly by its own transporter, the heme transporter or HT as shown here. The heme absorbed will then be broken down and the iron released as ferrous within the enterocyte. To continue, the incoming iron in the lumen that is in the ferric state is reduced to ferrous by a ferrireductase present on the surface of enterocytes. The transfer of iron from the apical surfaces of enterocytes into the cell is performed by a proton-coupled divalent metal transporter 1 or DMT1. This protein transporter is not specific for iron alone, as it can transport a wide variety of divalent cations, explaining how iron absorption is decreased by competing divalent metal cations like lead, zinc, etc. Once inside the enterocyte, iron has two fates. First, it can either be stored as ferritin, or secondly, iron can be transferred across the basolateral membrane into the plasma where it is carried by transferrin. Passage across the basolateral membrane appears to be carried out by another protein, possibly ferrous transporter or FP. This protein may interact with a copper-containing protein, hephaestin, a protein similar to ceruloplasmin. Hephaestin is thought to have a ferroxidase activity, which is important in the release of iron from the cells. Thus, ferrous iron is converted back to ferric iron, the form in which it is transported in the plasma by transferrin. As for regulation of iron absorption, it is still a complex subject not completely understood. As seen in the previous slides, iron absorption occurs at the level of the enterocyte. There appears to be two obscure mechanisms that affect iron absorption. The first is what is known as mucosal block, which basically means that the enterocyte blocks further absorption of iron if a sufficient amount has already been taken up, and secondly, there appears to be a force known as the erythropoietic regulation, which tends to explain that iron absorption appears to be responsive to the overall requirement of erythropoiesis, meaning if there is a need for more iron for red blood cell synthesis, the enterocytes are instructed to absorb more iron. Let us now proceed to the metabolism of iron. In a nutshell, here is an overview of iron metabolism. Iron is absorbed from the diet via transporters on the luminal and basal side of the enterocytes. Iron enters the blood where it is bound by transferrin. Part of the iron that is taken up is stored in the various cells in the form of ferritin. Most of the resorbed iron serves for the formation of red blood cells in the bone marrow, synthesis of cytochromes in the liver, and other important oxygen-carrying and storing proteins like hemoglobin and myoglobin. And as seen a while back, there is no physiologic pathway for the excretion of iron from the body. It is just lost from the body accidentally in the form of bleeding or physiologically during menstruation in the sweat, urine, and feces. This is a diagram showing the metabolism of iron from absorption to its loss from the body. Iron is absorbed from the diet, transported in the blood in transferrin, stored in ferritin, and used for the synthesis of iron-containing molecules. Because free iron is toxic, it is usually found in the body bound to proteins. Iron is carried in the blood by the protein apotransferrin, in which it forms a complex known as transferrin. Storage of iron occurs in most cells, but especially those of the liver, spleen, and bone marrow. In these cells, the storage protein apoferritin forms a complex with ferric iron and is now known as ferritin. Normally, little ferritin is present in the blood. However, this amount increases as iron stores increase. Therefore, the amount of ferritin in the blood is the most sensitive indicator of the amount of iron in the body stores. Hemosiderin is the protein in which excess iron is stored. Iron is lost from the body with bleeding and slough of cells in the sweat, urine, and feces. These are the key proteins that are involved in iron metabolism. Transferrin, abbreviated as TF, which is the serum ferric transport protein. Transferrin receptor, TFR, found on the cellular membrane for the cellular uptake of iron. Ferritin, important as a storage protein of ferric iron, and hemosiderin, a denatured insoluble form of ferritin. Let's start with transferrin. Transferrin is a beta-globulin with a mass of around 80 kilodaltons, which serves to transport iron in the blood. This monomeric protein consists of two similar domains, each of which binds a ferrous iron very tightly. If not bound to iron, transferrin is known as apotransferrin. It is a glycoprotein and is synthesized in the liver. It plays a central role in the body's metabolism of iron because it transports iron, quantitatively 2 moles of ferric ion per mole of transferrin, in the circulation to sites where iron is required, for example from the gut to the bone marrow and other organs. Approximately 200 billion red blood cells, or about 20 ml, are catabolized per day, releasing about 25 milligrams of iron into the body, most of which will be transported by transferrin. transferrin is usually only one-third saturated with iron. The total iron binding capacity of blood, mainly due to its content of transferrin, is approximately 300 grams per deciliter. Other transport proteins exist to transport iron. An example is lactoferrin, which is found in the secretions such as saliva, tears, and milk. Lactoferrin transfers iron and helps control the level of free iron in the blood. It is a multifunctional protein of the transferrin family, a globular glycoprotein with 80 kilodaltons molecular weight. Transferrin and the lactoferrins maintain the concentration of free iron in the body fluids at values below 10 to the negative 10 moles per liter. This low level prevents bacteria that require free iron as an essential growth factor from proliferating in the body. Transferrin and the lactoferrins are taken up into cells by receptor-mediated endocytosis, as we will see later in the discussion. The next important protein in iron metabolism is transferrin receptor, abbreviated as TFR. The transferrin receptor is a dimeric transmembrane glycoprotein receptor involved in iron transport. It is needed for the import of iron or uptake into the cell and is regulated in response to intracellular iron concentration. It imports iron by internalizing the transferrin iron complex through receptor-mediated endocytosis. All cells use some iron and must get it from the circulating blood. Since iron is tightly bound to transferrin, cells throughout the body have receptors for transferrin on their surfaces. Transferrin binds to these receptors, forms transferrin-transferrin receptor complexes which are internalized by receptor-mediated endocytosis. The complex is then internalized into an endosome where the pH is approximately 5.5. The acidic pH inside the lysosome causes the iron to dissociate from the protein. The dissociated iron leaves the endosome via divalent metal transporter 1 or DMT1 to enter the cytoplasm. Once released from the endosome, a transport molecule shuttles the iron to various points in the cell needing iron like the mitochondria. The excess iron binds to apoferritin and is stored as ferritin, the internal iron storage molecule. To continue, unlike the protein component of LDL, apotransferrin is not degraded within the lysosome. Instead, it remains associated with its receptor, returns to the plasma membrane, dissociates from its receptor, re-enters the plasma, picks up more iron, and again delivers the iron to needy cells. Iron storage. Ferritin is a universal intracellular protein that stores iron and releases it in a controlled fashion. It is the protein that stores excess iron and is found in most tissues, especially the liver, spleen, and bone marrow. Though found mostly within cells, small amounts are secreted into the serum where it functions as an iron carrier. Plasma ferritin is also an indirect marker of the total amount of iron stored in the body. Hence, serum ferritin is used as a diagnostic test for iron deficiency anemia. Ferritin is a globular protein complex consisting of 24 protein subunits forming a hollow sphere with multiple metal-protein interactions. Ferritin binds ferric ions and is deposited within the sphere as ferrihydrate. Ferritin that is not combined with iron is called apoferritin. Intracellular iron can be stored in ferritin and used for protein biosynthesis or to generate reactive oxygen species and regulate transcription via iron-responsive element-binding proteins or known as IRP. Export occurs through ferroprotein, often aided by hephaestin or HP and or ceruloplasmin, and repressed by hepcidin. Let us now look how the proper concentration of iron is maintained inside the cell or known as iron homeostasis. Cells have advanced mechanisms for sensing their own need for iron. In human cells, the best characterized iron sensing mechanism is the result of post-transcriptional regulation of mRNA. Sequences of mRNA called iron-responsive elements or IRE are contained within the mRNA sequences that code for transferrin receptors and for ferritin. Iron-responsive element binding protein or IRP binds to these mRNA sequences. On its own, the IRP binds to these iron-responsive elements of ferritin and transferrin receptor mRNA. What happens when there is a high iron concentration in the cell? When the intracellular iron concentration is high, iron binds to the iron-responsive element binding protein or IRP. The IRP changes shape with the result that the IRPs can no longer bind the ferritin mRNA. This liberates the mRNA to direct the cell to make more ferritin. In other words, when there is a high iron concentration in the cell, the iron itself causes the cell to produce more iron storage molecules or ferritin. Transferrin receptor production depends on the similar mechanism, but this one has the opposite trigger and the opposite ultimate effect. IRPs with iron will not bind to the iron-responsive elements on transferrin receptor mRNA. When the IRP is not bound to these sites, the IRE or the iron-responsive elements lose its stability and is cleaved, and the translation for transferrin receptor ceases. On the other hand, what happens if there is a low concentration of iron in the cell? When the intracellular iron concentration is low, very little iron binds to the iron-responsive elements binding protein or IRP. The IRP maintains its shape, which will allow it to bind to the ferritin mRNA. This inhibits the mRNA and thus no translation of ferritin occurs. Thus, when there are low iron levels within the cell, the lack of iron causes the cell itself to not produce ferritin. Concomitantly, in low iron concentration conditions, iron response elements binding proteins or IRPs allow the cell to keep producing transferrin receptors. IRPs without iron bind to the iron-responsive elements on transferrin receptor mRNA. When the IRPs binds to these sites, the binding not only allows for translation but also stabilizes the mRNA molecule so it can stay intact for longer. More transferrin receptors make it easier for the cell to bring in more iron from transferrin iron complexes circulating outside the cell to increase the intracellular iron concentration. Hemosiderin is an iron storage complex that is composed of partially digested ferritin and lysosomes. The breakdown of heme gives rise to biliverdin and iron. The body then traps the released iron and stores it as hemosiderin in tissues. Hemosiderin is also generated from the abnormal metabolic pathway of ferritin. It is only found within cells and appears to be a complex of ferritin, denatured ferritin, and other material. The iron within deposits of hemosiderin is very poorly available to supply iron when needed. Hemosiderin can be identified histologically with the Prussian blue stain. Iron in hemosiderin turns blue to black when exposed to potassium ferrocyanide. Disorders affecting iron metabolism arise either from having too little iron, like in iron deficiency states, or too much, such as the hemochromatosis. A reduction in iron intake can lead to untoward consequences. Most notably, a reduced iron level negatively affects the function of oxygen transport in red blood cells. Defects in iron metabolism can result from impaired intestinal absorption, excessive loss of heme iron due to bleeding, as well as to mutations in the iron response elements of iron-regulated mRNAs. On the other hand, too high concentration of iron in the body can be problematic as well. Iron can bind to and form complexes with numerous macromolecules, the consequences of which can be a disruption in normal activities of the affected complexes. Excess intracellular iron results in formation and deposition of hemosiderin, which can lead to cellular dysfunction and damage. Thus, the consequences of excess iron intake and storage can have profound consequences as well. Iron deficiency anemia, abbreviated as IDA, and also known as sideropenic anemia, is characterized by microcytic or small and hypochromic or pale red blood cells. Reduced iron intake and/or excessive iron loss results in a decreased globin protein content in red blood cells as a consequence of the heme control of globin synthesis. This results in decreased synthesis of red blood cells and consequently anemia. The cause of iron deficiency anemia can be classified as follows. First, from decreased iron intake resulting from inadequate diet, impaired absorption, gastric surgery, or celiac disease. Secondly, from increased iron loss that may arise from gastrointestinal bleeding caused by hemorrhoids, salicylate ingestion, peptic ulcer, and other causes. It can also be caused by the gastritis associated with chronic alcohol consumption. Increased iron losses can also be caused by excessive menstrual flow, frequent blood donation, and disorders of homeostasis. Thirdly, increased physiologic requirements for iron can cause iron deficiency anemia. This is frequently seen in infancy, pregnancy, and lactation. And lastly, if the cause is unknown, it is known as idiopathic hypochromic anemia. The symptoms of iron deficiency anemia attributable to the anemia include fatigue, dizziness, headache, palpitation, dyspnea, lethargy, disturbances in menstruation, and impaired growth in infancy. Treatment of iron deficiency anemia is to first determine the cause and source of the excessive bleeding. Oral administration of ferrous sulfate is commonly used to supplement the iron loss. However, intravenous iron therapy may be called in for in some cases. Severe iron deficiency anemia may necessitate transfusion with packed red blood cells. On the other side of the coin are the disorders caused by excessive iron in the body. This is exemplified by hemochromatosis. Hereditary or primary hemochromatosis, or also known as siderosis, is defined as a disorder in iron metabolism that is characterized by excessive iron absorption, saturation of iron-binding proteins, and deposition of hemosiderin in the tissues. This is caused by a defective gene that affects the transferrin receptor, resulting to uncontrolled uptake of iron into the cells. The primary affected tissues are the liver, pancreas, and heart. Iron deposition in the liver leads to cirrhosis, in the pancreas causes diabetes, and in the heart can lead to cardiac failure. The excess iron deposition in the skin leads to bronze pigmentation of the organs and skin. In fact, the bronze skin pigmentation seen in hemochromatosis, coupled with the resultant diabetes, leads to the designation of this condition as bronze diabetes. Secondary hemochromatosis is not caused by any mutation, is not inherited, and can result from any of the following etiologies: severe chronic hemolysis of any cause, multiple frequent blood transfusions, excess iron supplementation, either dietary or parenteral, excess dietary iron, and other disorders. Let us take some time to discuss the chemistry of porphyrins, which will help us fully understand the process involved in the biosynthesis of heme. Porphyrins are cyclic compounds formed by the linkage of 4 pyrrole rings through methynyl bridges. A characteristic property of porphyrins is the formation of complexes with metal ions bound to the nitrogen atom of the pyrrole rings. Examples are the iron porphyrins such as heme of hemoglobin and the magnesium-containing porphyrin chlorophyll, the photosynthetic pigment of plants, and cobalt-containing porphyrin of cobalamin. The porphyrins found in nature are compounds in which various side chains are substituted for the 8 hydrogen atoms numbered in the porphyrin nucleus as shown. The rings are labeled with the Roman numerals 1, 2, 3, and 4. The methynyl bridges are labeled as alpha, beta, gamma, and delta. And lastly, the 8 corners with the hydrogens are substituent positions labeled from 1 to 8 in a clockwise direction. As a simple means of showing these substitutions, Hans Fischer, the pioneer in the field of porphyrin chemistry, proposed a shorthand formula. First, the 4 rings are labeled as Roman numeral 1, 2, 3, and 4. Secondly, the methynyl bridges are omitted. And lastly, each chiral ring is shown as indicated with the 8 substituent positions numbered as shown here. The 8 corners of the porphyrin ring, the substituent positions labeled from 1 to 8, can be substituted by any of the following 4 molecules and abbreviated by their first letter: M for methyl, A for acetyl, P for propionyl, and V for vinyl. Please take note of each substituent's chemical structures. Let's look at the first example of a biochemically significant porphyrin, which is uroporphyrin 1. The arrangement of the acetate labeled as A and the propionate labeled as P, substituents in the uroporphyrin shown in here, is symmetric and follows a pattern. A comes before P, followed by an A, again followed by a P, then an A, and so on and so forth. A porphyrin with a completely symmetric arrangement of the substituents is classified as a type 1 porphyrin. Porphyrins with the substituent sequence is classified as uroporphyrin 1. On the other hand, let's look at the structure. We can see here that the arrangement of the acetate A and the propionate P substituents in the uroporphyrin shown here is asymmetric. That is, in ring 4, the expected order of the A and P substituents is reversed. The complete sequence A, P, A, P, A, P, P, A. The last 2 substituents positions again are reversed with the P coming before A. A porphyrin with this type of asymmetric substitution is classified as a type 3 porphyrin, and this specific porphyrin is known as uroporphyrin 3. Of all the series of porphyrins, only types 1 and 3 are found in nature, and the type 3 series is far more abundant and more important because it includes heme. For coproporphyrin 1 and 3, we can see here that the substituents are different: methyl M and propionyl P. For coproporphyrin 1, the substituents are M, P, M, P, M, P, M, P, which are in a symmetric configuration. Expectedly, in coproporphyrin 3, the sequence of the substituents is M, P, M, P, M, P, P, M, with the order of the last 2 substituents reversed and thus is considered asymmetric. The coproporphyrins were first isolated in the feces, but it is also found in the urine. Let us now look into what is considered to be the most important porphyrin, that is protoporphyrin 3, since this is the precursor of heme. Heme consists of a porphyrin ring coordinated with an atom of iron. The substituents are methyl M, vinyl V, and propionyl P. In heme, the order of these groups is MV, MV, MP, P, M. This order, in which the position of the methyl group is reversed on the 4th ring, makes it asymmetric and belonging to the type 3 series. Sometimes protoporphyrin 3 is labeled as belonging to series 9, since formerly it was designated 9 in the order of discovery by Hans Fischer. Here are the other representations of the structure of protoporphyrin 3. We can see the respective substituents here. Protoporphyrin 3, as we will see later, is the precursor of heme, which is complex with proteins to form hemoglobin, myoglobin, and the cytochromes, including cytochrome P450. We have discussed iron, its properties, and the chemistry of the precursor of heme, the porphyrins. We are now ready to tackle and discuss heme and its metabolism. Structurally, heme is a coordination complex consisting of an iron-ion coordinated to a porphyrin acting as a tetradentate ligand and to one or two axial ligands. Among the metalloporphyrins, heme is one of the most widely used and defines a family of proteins known as hemoproteins. As can be seen, it is a largely planar molecule, very stable with strong resonance features. Hemes are most recognized as components of hemoglobin, the red pigment in blood, but are also found in a number of other biologically important hemoproteins such as myoglobin, cytochromes, catalases, heme peroxidase, and the endothelial nitric oxide synthase. Here is an overview of the metabolic steps involved in the synthesis of heme. First, 3/4 of heme biosynthesis occurs mostly in the bone marrow for erythropoiesis and the rest in the liver for cytochrome and other protein requirements. Secondly, the organic portion of heme is derived totally from 8 residues each of glycine and succinyl coenzyme A. Thirdly, the reactions occurring on the side groups attached to the tetrapyrrole ring involve the colorless intermediates known as porphyrinogens. The latter compounds, though exhibiting resonance features within each pyrrole ring, do not demonstrate resonance between the pyrrole groups. As a consequence, the porphyrinogens are unstable and can readily be oxidized, especially in the presence of light, by non-enzymatic means to their stable porphyrin products. And fourthly, it is worthy to note at this point that the first and the last enzymatic steps are catalyzed by enzymes that are in the mitochondrion, whereas the intermediate steps take place in the cytosol. Let us now dive straight into heme biosynthesis. The first of 8 steps involves the synthesis of delta-aminolevulinic acid, or simply abbreviated as ALA. Succinyl coenzyme A, an intermediate in the tricarboxylic acid cycle, undergoes condensation with glycine and subsequent decarboxylation to yield delta-aminolevulinic acid, which we will just refer to as ALA. This reaction sequence is catalyzed by ALA synthase. Synthesis of ALA occurs in the mitochondria. Pyridoxal phosphate is necessary in this reaction as a coenzyme to activate glycine. Suffice it to know at this point that the ALA synthase is the rate-controlling enzyme in the porphyrin biosynthesis pathway. The ALA synthesized will now go out into the cytosol where the second reaction occurs. In the cytosol, 2 molecules of ALA are condensed by the enzyme ALA dehydratase to form 2 molecules of water and 1 molecule of porphobilinogen. As we can see in this structure, the pyrrole structure is recognizable. Therefore, porphobilinogen is considered as the first precursor pyrrole. ALA dehydratase involves zinc and is thus sensitive to inhibition by lead, as can occur in lead poisoning. The third step involves the formation of a linear tetrapyrrole known as hydroxymethylbilane. The formation of a cyclic tetrapyrrole, in this case a porphyrin, occurs by condensation of 4 molecules of porphobilinogen. These 4 molecules condense in a head-to-tail manner to form a linear tetrapyrrole, which we know as hydroxymethylbilane. The reaction is catalyzed by uroporphyrinogen 1 synthase, also named as PBG deaminase or HMB synthase. This is an illustration of the structure of hydroxymethylbilane. We can recognize the tetrapyrrole except that the ring structure is not closed but is still linear. In step 4, which is still in the cytosol, hydroxymethylbilane cyclizes spontaneously to form uroporphyrinogen 1, or is converted to uroporphyrinogen 3 by the action of uroporphyrinogen 3 synthase. Under normal conditions, the uroporphyrinogen formed is almost exclusively the 3 isomer, but in certain types of the porphyrias, the type 1 isomers of porphyrinogens are formed in excess. Note that both of these uroporphyrinogens have the pyrrole rings connected by methylene bridges, which do not form a conjugated ring system. Thus, these compounds are colorless, as are all porphyrinogens. However, as we will see later, the porphyrinogens are readily auto-oxidized to the respective colored porphyrins. These oxidations are catalyzed by light and by the porphyrins that are formed. Step 5 involves the conversion of the acetate groups to methyl groups by decarboxylation. Taking uroporphyrinogen 3 for example, it is converted to coproporphyrinogen 3 by decarboxylation of all the acetate or A groups, which changes them to methyl or M substituents. The reaction is catalyzed by uroporphyrinogen decarboxylase, which is also capable of converting uroporphyrinogen 1 to coproporphyrinogen 1. Clinically, the most common cause of porphyrin derangement is associated with patients who have a single gene abnormality for uroporphyrinogen decarboxylase, leading to 50% depression of the enzyme's activity. These diseases, which shows cutaneous manifestations primarily with sensitive to light, is known as porphyria cutanea tarda. We will be discussing this in greater detail later. The sixth step in the pathway involves the conversion of coproporphyrinogen to protoporphyrinogen. In this step, coproporphyrinogen 3 then enters the mitochondria where it is converted to protoporphyrinogen 3. Several steps are involved in this conversion. The mitochondrial enzyme coproporphyrinogen oxidase catalyzes the decarboxylation and oxidation of 2 propionic side chains to vinyl or V substituents to form protoporphyrinogen. This enzyme is able to act only on type 3 coproporphyrinogen, which would explain why type 1 protoporphyrins do not generally occur in nature. Step 7 involves the oxidation of protoporphyrinogen 3 to protoporphyrin 3. This is catalyzed by another mitochondrial enzyme, protoporphyrinogen oxidase. The reaction basically involves the oxidation of methylene or single bond CH2 single bond bridges to the methynyl or methine or single bond CH double bond bridges. To reiterate, this step occurs in the mitochondria as well. Let us now illustrate the differences between porphyrinogens and porphyrins. Porphyrinogens are tetrapyroles wherein the pyrrole rings are connected or bridged together by methylene or single bond CH2 single bond bridges. As we can see here, the conjugated system happens only within but not between the pyrrole rings. Therefore, there is no resonance within the whole tetrapyrrole structure. The porphyrinogens described are colorless, containing 6 extra hydrogen atoms as compared with the corresponding colored porphyrins. Thus, it is the porphyrinogens and not the corresponding porphyrins that are the actual intermediates in the biosynthesis of protoporphyrin and of heme. Because of the absence of overall resonance, porphyrinogens, however, are unstable and can easily be oxidized to their corresponding porphyrins. Once porphyrinogens are oxidized to porphyrins, we can see that the bridges between the pyrrole rings are converted to methine or methynyl or single bond CH double bond bridges. We can now see that the conjugated bond system is present throughout the whole tetrapyrrole structure. The conjugated bond system present throughout the porphyrins is responsible for the characteristic absorption and fluorescence of these compounds. This fluorescence is so characteristic that it is often used to detect small amounts of free porphyrins. To reiterate, the various porphyrinogens are colorless, whereas the various porphyrins are all colored. In the study of porphyrins or porphyrin derivatives, the characteristic absorption spectrum that each exhibit in both the visible and ultraviolet regions of the spectrum is of great value. An example is the absorption curve for the solution of porphyrin in 5% hydrochloric acid. Note particularly the sharp absorption band near 400 nanometers. This is a distinguishing feature of the porphyrin ring and is characteristic of all porphyrins regardless of the side chains present. This band is termed the Sorey band after its discoverer, the French physicist Charles Sorey. And finally, the last step in heme synthesis involves the incorporation of ferrous iron into protoporphyrin 3 in a reaction catalyzed by ferrochelatase, or sometimes referred to as heme synthase, another mitochondrial enzyme. To reiterate, the iron that is incorporated into the protoporphyrin 3 ring should be the reduced or ferrous state to produce heme. Similarly to ALA dehydratase, since this reaction is dependent on a divalent metal cation, ferrochelatase is also sensitive to the effects of heavy metals, especially lead, and of course to iron deprivation. The important biochemical concept of compartmentation plays a crucial role in heme biosynthesis. The last three enzymes in the pathway and ALA synthase are in the mitochondrion, whereas the other enzymes are cytosolic. Heme biosynthesis occurs in most mammalian cells except for mature erythrocytes, which we know do not contain mitochondria. Approximately 75 to 85% of heme synthesis occurs in the erythroid precursor cells in the bone marrow, and most of the remainder in the hepatocytes. Moving on, let's discuss the metabolic regulation of heme biosynthesis. As we have learned, ALA synthase controls the rate-limiting step of heme synthesis in all tissues. Succinyl coenzyme A and glycine are substrates for a variety of reactions. The modulation of the activity of ALA synthase determines the quantity of the substances that will be shunted into heme biosynthesis. Heme and also hematine acts both as a repressor of the synthesis of ALA synthase and as an inhibitor of its activity. Almost 100 different drugs and metabolites can cause induction of ALA synthase, which can cause exacerbations in patients with certain kinds of porphyrias. Glucose serves to inhibit heme biosynthesis in a mechanism that is not yet defined. This is of clinical therapeutic relevance. Does heme affect its own synthesis? Heme regulates its own synthesis by mechanisms that affect the first enzyme in the pathway, ALA synthase, in two ways. First, heme represses the synthesis of ALA synthase. Heme also affects translation of this enzyme and its transfer from the cytosol to the mitochondrion. Secondly, heme also directly inhibits the activity of the enzyme as an allosteric modifier. Therefore, the overall effect is that heme is synthesized when heme levels fall, and as heme levels rise, the rate of heme synthesis decreases. Heme also regulates the synthesis of hemoglobin by stimulating synthesis of the protein globin. Heme maintains the ribosomal initiation complex for globin synthesis in an active state. Many drugs, when administered to humans, can result in a marked increase in ALA synthase. Most of these drugs are metabolized by a system in the liver that utilizes a specific hemoprotein, cytochrome P450. During their metabolism, the utilization of heme by cytochrome P450 is greatly increased, which in turn diminishes the intracellular heme concentration. This latter event affects a derepression of ALA synthase with a corresponding increased rate of heme synthesis to meet the needs of the cells. Let us now move on to discuss the different disorders arising from abnormalities in the heme biosynthesis process. Porphyrias are inherited or acquired diseases that result from an abnormal metabolism in heme biosynthesis. The main causes are enzyme deficiencies that lead to heme pathways intermediates accumulation. Partial or complete deficiency of one of these enzymes result in different clinical pictures. There are 6 major types of porphyrias resulting from depressions in the activities of enzymes 3 through 8. However, we will just be discussing the 3 most common types, which are intermittent acute porphyria, porphyria cutanea tarda, and protoporphyria. As is true of most inborn errors, the signs and symptoms of porphyria result from either a deficiency of metabolic products beyond the enzymatic block or from an accumulation of metabolites behind that block. Before we discuss porphyrias, let us look on the profound impact on the sequential location of the particular enzyme affected on the symptoms manifesting that particular type of porphyria. If the enzyme lesion occurs early in the pathway prior to the formation of porphyrinogens, for example, enzyme 3, ALA and porphobilinogen will accumulate in body tissues and fluids. Clinically, patients complain of abdominal pain and neuropsychiatric symptoms. The precise biochemical cause of these symptoms has not been determined but may relate to the elevated levels of ALA or porphobilinogen or to a deficiency of heme. On the other hand, enzymatic blocks occurring in the later stages in the pathway result in the accumulation of porphyrinogens. Their oxidation products, the corresponding porphyrin derivatives, cause photosensitivity, a reaction to visible light of about 400 nanometers. The porphyrins, when exposed to light of this wavelength, are thought to become excited and then react with molecular oxygen to form oxygen radicals. These latter species injure lysosomes and other organelles. Damaged lysosomes release their degradative enzymes, causing variable degrees of skin damage including scarring. This image shows excessive skin lesions caused by photosensitivity as seen in severe forms of porphyrias. They are usually observed in areas of the skin that are exposed and not covered by clothing. Porphyria cutaneous tarda or PCT is the most common form of porphyria. PCT is caused by deficient levels of uroporphyrinogen decarboxylase. In approximately 75 to 80% of cases, this deficiency is acquired. In the remaining cases, individuals have a genetic predisposition to developing the disorder, specifically a mutation in uroporphyrinogen decarboxylase. Photosensitivity is the only major manifestation. Blisters developed on sun-exposed areas of the skin, such as the hands and the face. The skin in these areas may blister or peel after minor trauma. Increased hair growth or hirsutism, as well as darkening and thickening of the skin may also occur. In severe cases, scarring and disfiguration are not uncommon. Neurological and abdominal symptoms are not characteristic of porphyria cutaneous tarda. These are some images of the severe skin lesions caused by porphyria cutaneous tarda. These include blister formation, excessive hair growth or hirsutism, and scarring and disfigurement in very severe cases with complications. Acute intermittent porphyria or AIP is a rare metabolic disorder that is characterized by partial deficiency of the enzyme uroporphyrinogen synthase, also known as porphobilinogen deaminase or hydroxymethylbilane synthase. This enzyme deficiency can result in the accumulation of porphyrin precursors in the body. The majority of patients with AIP are asymptomatic. The initial and commonest manifestation is abdominal pain, which can be diffuse or localized, and colicky. The clinical picture may mimic an acute inflammatory abdominal disease. It is caused by an altered autonomic activity. Peripheral neuropathy is primarily motor, beginning in the proximal muscles, more often in the arms. Cranial nerves manifestations may lead to optic nerve atrophy. CNS abnormalities include seizures, delirium, and coma. Precipitating factors are drugs as barbiturates, sulfonamides, estrogens, and dietary restriction of carbohydrates. Diagnosis is made on clinical grounds and increased erythrocytic and urinary porphobilinogen and aminolevulinic acid levels. Protoporphyria, also known as erythropoietic protoporphyria or EPP, is a rare inherited metabolic disorder caused by a deficiency of the enzyme ferrochelatase. Due to abnormally low levels of this enzyme, excessive amounts of protoporphyrin accumulate in the bone marrow, blood plasma, and red blood cells. The manifestations include mild photosensitivity, which occurs after sunlight exposure. This is characterized by painful burning or stinging sensations, pruritus, erythema, and occasional edema. Mild abnormalities in the liver, biliary tract, and blood may be present. Diagnosis is made by detection of protoporphyrin in the erythrocytes. Allosyntase, as the key regulatory enzyme of the heme biosynthetic pathway in the liver, can be induced by a large number of drugs like barbiturates, antimalarials, etc. Most of these drugs do so by inducing cytochrome P450, which uses up heme and thus derepresses or induces ALA synthase activity. In patients with porphyria, increased activities of ALA synthase result in increased levels of potentially harmful heme precursors prior to the metabolic block. Thus, taking drugs that cause induction of cytochrome P450 and other so-called microsomal inducers can precipitate attacks of porphyria. High levels of lead can affect heme metabolism by combining with the sulfhydryl groups in enzymes such as ferrochelatase and ALA dehydratase. This affects porphyrin metabolism. Elevated levels of protoporphyrin are found in red blood cells, and elevated levels of ALA and coproporphyrins are found in the urine. The treatment of the porphyrias is essentially symptomatic. The following are recommended. First, patients should at all costs avoid drugs that cause induction of cytochrome P450. Secondly, ingestion of large amounts of carbohydrates or glucose loading or the administration of hematine, a hydroxide of heme, may repress ALA synthase, resulting in the diminished production of harmful heme precursors. Thirdly, patients exhibiting photosensitivity may benefit from the administration of antioxidants like beta-carotene. This compound appears to lessen production of free radicals, thus diminishing photosensitivity. And lastly, sunscreens that filter out visible light can also be helpful to such patients. The last part of this discussion involves the degradation or catabolism of heme. This illustration shows the pathway of heme from its release by the dying red blood cells to its excretory products in the urine and feces. As we all know, heme is mainly found in the human organism as a prosthetic group in red blood cells as hemoglobin. Around 100 to 200 million aged erythrocytes per hour are broken down in the human organism. In a day, a 70 kg human turns over approximately 6 grams of hemoglobin. When hemoglobin is destroyed in the body, globin is degraded to its constituent amino acids, which are reused, and the iron of heme enters the iron pool also for reuse. The iron-free porphyrin portion of heme is also degraded, mainly in the reticuloendothelial cells of the liver, spleen, and bone marrow. After the protein part or globin has been removed from hemoglobin, the tetrapyrrole ring of heme is oxidatively cleaved between the rings 1 and 2 by the enzyme heme oxygenase. This reaction requires molecular oxygen and the reducing equivalent NADPH plus H and produces the green biliverdin, as well as carbon monoxide and ferrous iron, which goes back to the iron pool for further use. To continue, in another redox reaction, biliverdin is reduced by biliverdin reductase to the orange-colored bilirubin. The color change from purple to green to yellow can be easily observed in vivo in a bruise or hematoma. The color of heme and the other porphyrin systems results from their numerous conjugated double bonds. Heme contains a cyclic conjugation that is removed by the reaction catalyzed by heme oxygenase. On the other hand, the reaction catalyzed by biliverdin reductase breaks the pi system down into two smaller separate systems. It is estimated that 1 gram of hemoglobin yields around 35 milligrams of bilirubin. The daily bilirubin formation in human adults is approximately 250 to 350 milligrams, derived mainly from hemoglobin but also from ineffective erythropoiesis and from the breakdown of various other heme proteins such as cytochrome P450. For further degradation, bilirubin is transported to the liver via the blood. As bilirubin is poorly soluble because it is highly nonpolar, it is bound to albumin for transport. A number of compounds such as antibiotics and other drugs compete with bilirubin for the high affinity binding site on albumin. Thus, these compounds can displace bilirubin from albumin and have significant clinical effects. In the liver, the bilirubin is removed from albumin and taken up at the sinusoidal surface of the hepatocytes by a carrier-mediated saturable system. This facilitated transport system has a very large capacity, so that even under pathologic conditions, the system does not appear to be rate-limiting in the metabolism of bilirubin. Next, the hepatocytes take up bilirubin from the blood and conjugate it in the endoplasmic reticulum with the help of uridyl diphosphate glucuronic acid into the more easily soluble bilirubin monoglucuronides and diglucuronides. This conjugated form of bilirubin is polar and therefore water-soluble and is excreted into the bile. The conjugation of bilirubin with UDP glucuronic acid involves the enzyme UDP glucuronylyl transferase, or shortly known as bilirubin UGT, that forms ester-type bonds between the OH group at C1 of glucuronic acid and the carboxyl groups in bilirubin. The ionic carboxyl groups of UDP glucuronic acid will now render the whole conjugated bilirubin polar and therefore water-soluble that will now be excretable. Glucuronide synthesis is the rate-determining step in hepatic bilirubin metabolism. Drugs such as phenobarbital, for example, can induce both conjugate formation and the excretion of bilirubin. The glucuronides are then excreted by active transport into the bile, where they form what are known as the bile pigments. Some of the bilirubin conjugates are broken down further in the intestine by bacterial glucuronidases. The bilirubin release is then reduced further via intermediate steps into the colorless stercobilinogen, some of which is oxidized again into orange to yellow-colored stercobilin that gives a brown color to the feces. The end products of bile pigment metabolism in the intestine are mostly excreted in the feces, but a small proportion is resorbed via enterohepatic circulation. When high levels of heme degradation are taking place, stercobilinogen appears as urobilinogen in the urine, where oxidative processes darken it to the yellow pigment urobilin that colors the urine yellow. When bilirubin in the blood exceeds 1 mg per deciliter or 17.1 micromole per liter, hyperbilirubinemia exists. Hyperbilirubinemia may be due to the production of more bilirubin than the normal liver can excrete, or it may result from the failure of a damaged liver to excrete bilirubin produced in normal amounts. In the absence of hepatic damage, obstruction of the excretory ducts of the liver by preventing the excretion of bilirubin will also cause hyperbilirubinemia. In all these situations, bilirubin accumulates in the blood, and when it reaches a certain concentration, it diffuses into the tissues which then become yellow. This is known as jaundice or icterus. The figure illustrated here summarizes the three major processes involved in the transfer of bilirubin from blood to bile and the different conditions associated causing hyperbilirubinemia and jaundice. We will not be discussing this in greater detail, but it is worthy to note that any obstruction in the pathway for heme catabolism and subsequent bilirubin excretion can give rise to hyperbilirubinemia and the clinical manifestation of jaundice. The obstruction to bilirubin excretion can be prehepatic, hepatic, and posthepatic. The location of the obstruction will impact on the type of hyperbilirubinemia that will ensue, whether indirect or direct or both, determining which is, however, beyond the scope of this lecture.